this new reforms.
Okay, and we are live. Welcome back to the All Things Aged Care Weekly Wrap-Up. My name is Anthony Nguyen, aged care recruitment expert and host of the Pioneers in Aged Care podcast. I'm currently recruiting for several clinical and leadership roles, but if you're an occupational therapist, a nurse practitioner, or a clinical care manager, please get in touch urgently. Next, we have Robert Covino, founder and CEO of Mirrors Australia. He led the creation of technologies like Mirrors Metrics and Care Minute Manager, and now Mirrors Plus, an AI-powered platform uniting software and data to streamline everything from admissions and compliance. Rounding out our hosting crew is normally Owen Matheson. He's not here at the moment, but I'm going to give the introduction anyway because he will hopefully pop on sooner rather than later. Owen,
coming in hot
out there. Yeah. If you're out there, give us a thumbs up in the comments. So Owen Matheson, strategic connector and founder of Mission Critical Group, who works with owners, boards and executives with a knack for connecting the right people, opportunity and capital to unlock growth and drive innovation. Now, our special guest for today is the CEO and founder of Boucher Advisory Group. She has over 20 years of experience in the health and aged care industry and specializes in advisory and operational governance support to commercial and not-for-profit organizations. She works alongside Australian aged care providers to help them navigate the complexities of compliance and uncover any gaps they did not know existed. She's here today to discuss a new model of care that supports rural and remote aged care providers who are grappling with little to no GP support, and of course to discuss all things aged care. Ladies and gentlemen, please raise the roof for Sherrie Boucher.
Thank you.
Hey, Sherrie. Well, welcome, Sherrie. Friday, big week. These weeks do feel longer and longer as they play out. But I thought maybe just give us a little bit of an overlay. What is a nurse advisor, and what role do they fulfill in this? A crucial role do they fill in this industry? For those that are a little bit, I'm trying to understand where you fit in, and so that the next element we can expand on more.
Well, it's a very broad role. So the term nurse advisor, it applies to a registered nurse who is able to go into an aged care facility. Usually when a facility has had a commission visit, whether it's a performance visit or a reaccreditation visit, and something hasn't gone fully as they expected, usually resulting in a not met or a sanction. So quite often nurse advisors are appointed in these particular situations, and they work very closely with the provider to remediate any areas that need that turning around for the commission to be in line with.
So you're a fixer. You're the wolf, to quote Quentin Tarantino.
That's the way of putting it. Putting out spot fires, fixer. The range of words to be described.
Last minute resort, right? Like the SEAL Team 6, or is it Delta? The Delta team, whichever one of them is higher.
I like the A team. The A team is something
the A-team.
Where you parachute in and just the team diversifies and
just let's go.
I love that. Yeah, that's right. Sometimes, not always. So what is so I would assume you have extended powers from the new reform. So nurse advisors, they can really call the shots when a home is put into effectively a sanction or an area. You're appointed, right, as the body, the stand-in director.
So
is that correct?
When the commission has appointed under the new act, they've got a new term called statute manager. So if you're a nurse advisor with experience, and then you're appointed as a statute manager, then you're representing the commission on site. So yes, the powers are a lot stronger. It really depends on the situation. So a nurse advisor can go in to remediate and support providers not in sanctions. They might just be really concerned and want a gap analysis because they've got an upcoming commission visit or upcoming reaccreditation, and they're just not sure. So you can be in an informal way or a formal way as a nurse advisor.
Well, November 1st did bring in some significant changes. And how did that impact on your roles? Is things different? Are they moving? Is it busier? Is it quieter? Where are we at?
Well, we've pretty much hit the ground running. We've had a lot of inquiries for pre-accreditation gap analysis. A lot of providers are really concerned about the new pre-registration tools and the completion of those tools, and they're just not quite sure, where their company sits in relation to the preparation for re-registration. So we've had a lot of inquiries for that. And then just general remediation work. It's really quite busy out there at the moment.
So remediation works, that's a big word. For us laymen who are not in the clinical space, give a little bit more color to remediation. And I guess where I'm going to go to next with this is also, what are some of the linkages you're seeing, and specifically workforce sides? But can you cover off the remediation side of it?
Yeah, so remediation is a very broad term. It really stands for something that is not in line with the current legislation or the current standards. So if you're a provider, you might have done an internal audit, you might have had a commission visit, or you might have had a complaint. It could be anything, and you've identified that something's not quite right, something's not quite in alignment, and you need support to go in, you need external support to fix that particular area of non-conformance. So that's really what remediation means. You've got something that's not aligning with the standards or the Act.
And we do have some new standards in our new Act in place. So I think the big question I keep hearing, that Australia's aged care industry is in crisis. But I do want to challenge that word, crisis, mainly because a crisis implies something sudden. Now, what if this actually been slow, predictable, maybe it was predictable collapse that nobody chooses to stop, but where are we within that? You mentioned hitting the ground running, but what does that look like out there, and the type of work you're now undertaking post November 1st?
I think providers are under a lot of pressure in general. They're trying to navigate their way through the new legislative act, the new standards, and then on top of that, the new registration requirements. So they've had it's a triple triangulation attack that they've got to get their heads around. So there's not one provider out there that I don't know that is actually really struggling to get their head around these reforms. It's a huge amount of work that needs to be done: back house, front house, policies, procedures, workforce models. It's very, very, it's a lot of work.
Absolutely. And I think, we are a country of 24 million people. And when you look at that in the context of just our niche industry and those who support it and work in it and provide the care in it, we hear about this measure of 1 in 4 aged care workers are also about to retire, which is also quite scary when we just need more, I think is the common feedback I receive. But at the same time, the demand for care is about to explode. Like, we're at the bottom of a hockey stick that is a bit concerning too, because some of the stats that I've even heard about, our first baby boomers are just turning 80. Now, the average age for entry into these services is 82 and a half from our data sets. But it looks like we do have a bit of a workforce crisis, I guess, coming back to that opening question. So I guess when you look at that side by side, what does that actually mean for maybe in a family trying to get into care, or even a worker, or perhaps even trying to retain some of the people today? Because yes, we need to retain, but also bring in a lot more. And also I am concerned for our sector as we have a big load of people coming our way.
I think the workforce crisis is still really, really relevant today. And I see it in a lot of the providers I go to where they're short-staffed, they're having to rely on agency a lot, and the agency costs are blowing the operations out. So that is certainly hurting a lot of providers. That's not going to change anytime soon. The other thing I wanted to put into the picture is also the accommodation issues. So sometimes the solution is to get overseas workers, and providers actually want to go down that path, but then it's complicated in rural and regional and remote where there's no accommodation to house any particular candidates coming from overseas. So that is a huge problem as well, just not enough housing to host these potential staff members for stabilisation. So, I think it's a twofold effect. It's not just about attracting and retaining. It's about finding a place for them to live as well.
Yes, that's a good point, because I think anyone who's in a major city struggled with A, affordability, but B, even supply of dwellings. Just thinking about around my neighborhood and seeing lines of people waiting to look at a rental and things like that is it's quite unprecedented. But I do want to shift a little bit more to some more exciting news, though. Tell us, you're onto something big, a new launch, a new business with some other nurse advisors and specialists in the sector. Can you share more about what that looks like and what's going on?
So I guess if we're referring to the nurse practitioner model of care here, so about 18 months ago, we had a call from a provider in regional New South Wales who had a urgent and abrupt departure from their GP in the town. And at the time, there was potentially up to 40 residents that didn't have any medical support. And now that provider had reached out to multiple peak bodies with no resolution in sight. And I can just remember getting a 6 p.m. phone call on a Friday night asking for help because I just presented on the nurse practitioners and how they're the way of the future, and that many aged care providers now have them in place, and I can really see them doing a great amount of positive work in rural and remote. So when I got that phone call at 6 o'clock on Friday, I just landed in Bali for the aged care conference. So it was great timing.
Wait,
and
aged care conference in Bali. Tell me more about that later.
Yeah.
I missed that one.
Another time. So we really, that 6 o'clock phone call, I'll never forget it. Her words were, "We need to start the nurse practitioner model now. We've got 3 weeks left of prescriptions, and then that's it. We're out. We've got no cover." So it was quite a birthing of this particular model of care from theory to putting it into practice in real time. It took us about a week to source a nurse practitioner that was willing to come and work with us and work with this provider on a long-term basis. So
it took you only a week to find a nurse practitioner.
A week.
That's amazing.
Yeah, so I put the call out on LinkedIn and interviewed a couple of people, and the wonderful Georgia Alice was connected through the LinkedIn call out, and I'm really excited to say that she was really willing to give it a go, and it's a first of its kind. And so I'm really proud that she has been on this journey with us, this new model of care.
Well, that's awesome. Should we add Georgia on now?
So, yeah, I think that'd be great.
All right.
Hey, Georgia. How are you today? Georgia.
Hey, I'm well, thank you, guys. How are you?
Doing pretty well.
Rob
and I were
good.
Rob's still in Tasmania, I think. I just got back today.
Yeah, it's
beautiful Tassie.
It was awesome. And I'm in Sydney now, which I'm very grateful you confirmed the time with me, because I otherwise would have been an hour early, which can't hurt.
I've had a few mix-ups with that. But just with this model, so this the nurse practitioner, because I've had clients reach out to me to find nurse practitioners, and for those roles, they're permanent placements. So I'm looking for nurse practitioners to join a aged care provider. Is this when they asked you to find a nurse practitioner, or you found Georgia? Georgia, are you how does that work? Are you under a different company, under a different entity? How does that business work?
So, do you want to answer that? You're happy to answer that, Georgia?
Oh, I'm sort of my own entity, I guess you could say. I'm self-employed nurse practitioner, and Sherrie came across through connections, like she said, through LinkedIn. So yeah, I'm not under I'm a contractor to Sherrie's firm.
Gotcha.
And then I was placed in the Corindi facility. and that was over a year ago now, well over a year and a half or so now. Time flies. But yeah, as I'm sure Sherrie or myself can explain, it's a very unique model. It's not the typical, what we see in Sydney a lot, where a nurse practitioner will be contracted by the facility to support the existing GPs within the facility, or perhaps be employed by a facility to work there on a more, Monday to Friday basis and support across the board all of the residents. This placement was the nurse practitioner being there in lieu of a GP. There was a crisis where there was no GPs available, and so I stepped in as the primary practitioner for 40 residents. Yeah.
For those who don't know, for those who are looking at nursing and nurse practitioner as a career pathway, they just logged on to this show right now and they think they want to work in aged care. What's the difference between a nurse practitioner and a GP?
Is that me to answer?
Well, yeah, go ahead.
Okay, so, nurse practitioners are registered nurses by background, so that would be the biggest difference. But in our career pathway is different as well. We, start out doing your Bachelor of Nursing and you become registered as a registered nurse, and then the training then is you work with at least 5 years of registered nursing experience, with 3 years of that time in a specialty, and then you do a master's degree, which is a very supported sort of placement on the job master's degree in your chosen specialty, mine obviously being acute geries and aged care. So, but in terms of the scope of practice in comparison to a medical doctor, nurse practitioners are considered highly skilled with over 5,000 hours of specialty experience. We work collaboratively with medical and allied health professionals, and then we are qualified to perform sort of the more comprehensive assessments, making diagnoses, ordering pathology and imaging, prescribing medication, providing specialist referrals. And then as well, sort of similarly to a medical doctor, we can receive eligible for a Medicare rebate through our interventions.
So in the context of aged care, it seems like you can do everything that a GP can do.
Yeah, this is, yeah. So it's pretty much within a nursing, my role in the facility that I'm in, my scope of practice is almost identical to what a GP would be doing for these for the residents in the nursing homes. The caveat is that we can't certify deaths. So unfortunately, that is a huge hurdle that we've had to, sort of manage. Obviously, in my opinion, it's a really big barrier to nurse practitioners because we look after these patients. We're essentially their primary practitioners. We know them inside and out. And then at the very end of their life, we're not able to just, sign a death certificate. So that's one of the things. The other thing is there's a few things that we can't refer for a Medicare rebate, like specific CT, MRIs, MRI brains. We can still refer, but the patient wouldn't attract a cover.
Putting your tinfoil hat on, what reasons would you be able to put forth as to why a nurse practitioner can't certify a death?
I honestly think it's just it is I think it's like an antiquated piece of policy that was put in place years and years ago, when our medical doctors were the biggest part of our workforce, and nurse practitioners, and even now, are most people don't know what they are. And so I think that's just the reason that it's just been the status quo and no one's really challenged it. And, until now, or until this becomes more and more of an issue, when nurse practitioners are taking up care of these residents, especially.
Yeah, definitely seems a way of keeping the hierarchy. Well, that was my thought.
Yeah,
Don't mean to upset any GPs out there,
probably not wrong. It's maybe just that little stake that they have in that level of responsibility for them.
Sherrie, anything to add to that?
Yeah, look, I will say that I do think things will change quite rapidly. I have been in contact with the colleagues at the ACN, and there will be some media statements going out over the next day or so, but the legislation has passed, and so nurse practitioners now can certify deaths in the ACT, which is wonderful, wonderful news. So it is coming. It is coming. I don't envisage the other states will take too much longer. So I do think that this change will be very, very soon applied to the rest of the states, particularly if ACT has been granted that legislative change, which is really fantastic. And there's some other things. There's some other things that nurse practitioners can do in legislation within ACT now. So that'll be interesting to watch those media releases come out over the next day or so. I guess one of the things I wanted to touch on is the model of care in its entirety, so that if there's any other aged care providers out there that's really struggling with their GP coverage, particularly in the areas of governance as well. So within aged care, we've got a lot of governance that we have to do in terms of medication management. You've got your polypharmacy, you've got your restrictive practices, you've got your psychotropic medications, you've got your chemical restraints, you've got a whole host of requirements that need to be met to make sure that we're meeting the standards and the Act. And I know that rural and remote often don't have GPs that have the time to do those comprehensive reports that are required by the Commission, or, they don't have the time to fill out all that documentation. So under the model that we've got for providers, it's particularly beneficial for the compliance. So Georgia really maintains those conversations with the families and really does live education with them around the benefits of any particular medication, chemical restraint, when they're going into palliation. I would say, Georgia, you go above and beyond your role where you are at the moment, and it's really evident that the residents and the facility, they're just so happy and they're well cared for, and the documentation is just it's very, very comprehensive, a lot more comprehensive than I think what you would get if you had a 3-minute visit from a GP. And it's not from any fault of their own, it's just there's just not enough resources out there for rural and remote GPs to be able to spend the time to do what's required to meet those governance expectations. So under this model, if there is a rural and remote provider out there that's really struggling, we'd love to hear from you, and we'd love to have a chat and talk you through how we can support you. With this model, Georgia flies in once a month and she sees about 20 clients in that particular day. Is that correct, Georgia? Yeah.
Yeah.
And then she flies back on that same day. And then in between, we have what's called telehealth. So telehealth once a week at a set time. So there's that continuity of care. So they're getting that weekly touch point in between every on-site visit. And in terms of the costs and things like that, it's really the travel that's not funded. So as Georgia was saying, Medicare covers a lot of her requirements and reviews with the residents, but the travel is not covered by any funding stream. So this is where we're really pushing with the government to get some models of care and some funding and resourcing for the travel, because it's really the provider has to pay for that travel. That's where a lot of the cost comes in.
That's really interesting. I think one of the things I wanted to touch on in there is I want to bring it back to something quite personal in that, and for both of you to speak to. But we're talking about the model of care, about the data, about the policy and the workforce numbers. But behind every one of those statistics is a family. And what's the story that stays with you? The one that made you realize the system needed to change or gave you that passion to to take this on every week and every day.
Is that you want Georgia, or who are you wanting to answer that?
Both of you. You both play a vital role in this. So I'm sure you both have. I call it the why. What is your why, or what's the story, the human moment in this too? Because at the core of all this, we do this for something special, something that drives us to get out of bed and look at this job and look at this industry in a different way, in a different light, and to make it better, make aged care better, but also think about those humans that you've really had an impact on. Or share some of those stories over the years, because I'm sure you have a few of them. Probably write a book, right, Sherrie?
Yes, that's true. Look, I guess, Georgia, if you're happy for me to chip in first, I know you've probably got some wonderful things to say as well, because I have heard quite a few beautiful stories and we've had quite a few conversations, but as to why we're doing this. But I guess my passion is innovation. I love to be able to give back to the community in different ways, because aged care is really struggling out there in terms of where everybody is at to try and make compliance, and I think innovation's the key. But also not, having that passion. I've got a real passion for aged care, and I think that I'm not sure if I was born with it, but for whatever reason, I love working in aged care, and I always have. So even when I was in university, I think I wanted to work in aged care. Straight after my grad year, I went into aged care. It just for me, it's been my passion and my love. And I'm particularly fond of rural and remote, and feel like if we can support them in any way possible with innovative, cost-effective ways, I think that's what it's all about. So that's where my drive is.
Georgia, we'd love to hear your why as well.
Yeah, there's lots of whys. I think when Sherrie first approached me, obviously I have a young family and it's a long way away from home. But I think just going that first day to that facility out in Corindai and just meeting the residents and just seeing the smiles on their faces, they're just really lovely, down-to-earth people that have just had a great life, and then were so thankful that somebody was there and willing to take time to talk to them about their health and whatever it might be, the family situations that they're in, or just some beautiful stories of their life, just someone to take the time to sit with them and care about them. So I think that was really the why for me, in that just even a very small change in their healthcare can make a big difference to them as a person. And I mean, across the board in my nursing career, I always wanted to go into nursing. My mum's a nurse. But I was the same sort of as Sherrie, in that I was always drawn to aged care. I just find the older population so much more interesting, and medically as well, I think they're more complex, which, is often a bit of a debate with my medical peers who go into pediatrics and adults and surgical and things like that. But the older people with so many potential comorbidities, it's just like a big puzzle to me. So I like that element of it too.
No, I love that. And is Corindai the name of the location or provider?
Corindai is a town.
Okay.
It's about 50 minutes from a drive from Tamworth. So and the nursing home is called Kurindai Care Services.
Okay, so they're a standalone?
They're part of Apollo Care now.
Oh, of course I know that. Yeah, that's why rings a bell. Yeah, we've had Stephen Becci on here, and I've had him on the podcast. At this point, he's pretty much a friend. I've spoken to him so much and caught up with him a bunch of times. But I love their model. So good on you for supporting them. Rob just messaged saying he's about to board his plane, so he's going back to Sydney. He's getting on there, so he's logged off. But we can carry on. He did put in a question, but before we ask his question, Kim Davis, friendly face of the show, asked a question about the model that you described. Would that model work in home care support at home as well?
I can't see why it wouldn't, Georgia. I mean, going to a resident's aged care facility is no different to going to their home. Is that correct?
Yeah, it definitely could work. It's just getting the volume of work from, for a nurse practitioner. Obviously, there's not a lot of home visiting GPs, and for those clients that are pretty housebound and find it difficult to get out to see their GP, nurse practitioners coming into the home is a really workable model, but it's just for that model to work, there would need to be some degree of sort of volume for them.
And the other thing too, Anthony, it's the funding stream. So it's the travel time. So if you're seeing somebody in their home and you might live in Sydney Metro and they're 2 hours away, you've got a 2-hour drive that's unfunded through Medicare. And then you've got to see the client that is funded through Medicare, but then you've got to get home again or you've got to go somewhere else. So it is really the travel component that, because it's not funded by any income stream under the government, there's just no funding for it at the moment. So, we really want to be able to support, home care and residential aged care, but the cost of sending somebody out, like Georgia said, the volume of residents, it can be quite challenging from that perspective.
So who do we have to talk to about that?
Well, we've been advocating it at the moment through the budget in the federal budget, so that we can get a bit of exposure for the nurse practitioners and really trying to get even some pilot programs out there to see how this could work in the home care setting, because I think that's very, very important. With residential, you have residents clustered together. So, the volume is already there. But at home, that's certainly a big, big concern.
Is there a particular person that you'd want to sit in front of and talk to about that?
I think, well, obviously you would be starting with the health minister to begin with, and I'm sure that somebody here out there is actually watching this. Will definitely pass this conversation on to them, no doubt.
So if you say, I think there's this new AI feature on this platform. So if we say the words "clip that" later, there after this is done, it'll produce a little clip, and then you can share whatever you want that particular section on your social media. So we're going to try that. We're going to try. Maybe I'll get you to put a few words to whoever it is, and then we'll say "clip that," and then we'll send it to you. We'll spam. Everyone will spam their LinkedIn with that particular video. But relevant question from Miras Australia here. So if you could sit in front of the Minister for Aged Care today, not for a photo opportunity, not for a press release, but for a real unfiltered conversation, what's the one thing you would ask them? Both of you need to answer this. Oh, wait. There's a second part of the question. What's the one thing you would ask them to do differently? So I guess you could. So what's the one thing you can ask them, or what's the one thing you would ask them to do differently? Either or.
I'd probably ask them to look at the nurse practitioner items within the MBS and see how they could do those differently and make it more equitable to a GP's assessments in an aged care context.
Yep. clip that. See if it works.
I would like to see I would like to see some sort of a subsidy for aged care providers who are in rural and remote who are struggling with GPs. So, if they were to implement a nurse practitioner model of care, it would be great if there was a grant or an opportunity to support that model, because the provider does have to pay for the travel and any nurse practitioner fees that may be there for that day visit. And if there was an opportunity to get a subsidy or some sort of an incentive to make that model more equitable for rural and remote providers, particularly those who are very small, like 30 beds, 40 beds, who are really struggling, really hurting, that would be great. If there was some sort of financial subsidy applied for them, that would be fantastic to offset the cost of the fly in and the fly out.
And clip that. Okay, this I want to show you a little bit. I want to show you a post of your fellow nurse practitioner. Do you know Prosper Bamford? She's I met her at the Positive Aging Summit last year, and I've been following her. She's been following me for some time, and she's probably the first nurse practitioner in aged care that I got to know. And she posted this 3 weeks ago, but I only saw it yesterday. And I just want to give her a shout out to congratulate her for being selected to receive a place on the Florence Nightingale Foundation Leadership Scholarship. So congrats, Prosper. I thought it'd be a apt time to give you a shout out, seeing as this whole thing is about nurse practitioners and what you guys do for the sector. So she's a big advocate for aged care, and she's doing the best she can. And I look forward to catching up with her in Adelaide in a couple of months. I have asked her to be on, but she's pretty full on at the moment. For those who are tuning in right now, we've discussed the nurse practitioner model as it pertains to aged care, talked about the career pathways. I mentioned at the beginning, I have been engaged by a client to look for a nurse practitioner to join the organization on a permanent full-time basis. It's not an easy role to fill, and that's why they came to me. And this is the sort of platform, and it's just perfect timing that we had you two as guests today. So hopefully people in your network are watching this, and we can clip that and send that around to them as well. What, in terms of numbers, do you know the figures as to how many nurse practitioners there are in Australia, or how many work in aged care?
Not off the top of my head.
I think I saw the number. I could be wrong, but I saw the number 3,000 somewhere, or maybe that could be.
I think there's I think the last estimate was like 2,800 or something in Australia, which is really not a lot at all.
No. But
I'm not sure how many in aged care. You could probably easily look that up. But
yeah. So yeah, and not a huge not a huge pool of talent to choose from. And hopefully we can get a good number of those nurse practitioners to consider aged care. Now, there was a question when you talked about the nurse advisory, where I guess I wonder who chose when there's when remediation needs to occur, who chooses which nurse advisor that goes? Is it the commission or is it the aged care provider?
The aged care provider, if chooses who the nurse advisor is, and depending on what the regulatory action is, they need to report that to the commission, and then the commission would need to approve that nurse advisor.
Okay. I've got some questions around that because I'm still figuring out how that all works, but I'm not sure if I know how to articulate them so well right now. We're live, so I'm not going to try. I'm going to think about that for a little bit and come back to you maybe offline and pick your brain on it a little bit more. But if anyone else out there has a question about how it all works, please send the questions through so that I can continue learning about it as well. Is there anything that we haven't covered yet? Was there anything that you wanted to touch on today?
I think we've covered it pretty well, haven't we, Georgia, in terms of what we do and how we do it. I'd like to say that, it probably took about 6 months to really establish this model of care, to make sure it was running smoothly, because we did hit a few road bumps along the way in terms of things like EPC referrals. We certainly found that out along the way, where, that can only be a GP that actually refers for the EPC. So that was a barrier that we had to work through, quite a significant barrier. But we have managed to work through some of those things, as well as the death certificates as well. So we've found solutions to some of those little roadblocks that we had in the earlier days, haven't we, Georgia? And I think it's running very smoothly now. There hasn't really been any, it's just ticking along, isn't it, really?
Yep.
Well, great.
Yeah, it's really
Lexi
great.
Methral, she was actually backstage before, but I think maybe she couldn't get her camera
Here
working.
she is here. She's asked a question.
Yeah, so she says, in support of what you said, need to be doing more to support nurse practitioner-led models like Sherrie and George's in aged care and everywhere. So shout out from Lexi to your model.
Thank you,
to anyone wanting to reach out to you guys, you want to plug your contact details so they can reach out to you to talk more about this? Email address maybe would be safest rather than your personal phone number.
Sherrie?
Social accounts.
Of course.
I heard the term. They said you can follow me on Twitter. You can follow me on.
I don't think LinkedIn we ever.
Follow me.
We don't have a handle on LinkedIn. But if anyone wants to reach out to either Sherrie or Georgia, just follow them on LinkedIn. Send them a connection request.
Yeah,
that's probably the best way.
Yeah,
definitely.
Sorry to put you on the spot and tell you to put on blast your contact details. I'm a recruiter. I'm used to asking for those sort of things, but maybe not in a public forum. Rob is still online. Rob, I think we're ready to wrap this up. If there's anything else, any other questions, any other comments from anyone, including yourself, Rob, do you have any more thoughts to throw out to Sherrie and Georgia?
I just wanted to say thank you to both of you for what you do in this industry, and you play such a vital role in it. So keep doing what you do, and we'll keep doing what we do, and we will continue to make aged care better.
Awesome.
Right.
Thank you, Rob.
Thank you very much.
Thanks, guys. Play us out, Rob. I don't know if you can from the plane, but I guess we'll say goodbye there. Catch you all next week.
Awesome. Thank you.
See ya.
Bye-bye.